Good morning. We are at TCTAP 2016. I have a wonderful panel from right to left. Philippe Urban from Switzerland, Michael Haude from Germany, and Stephen Ellis from United States. And we will have 30 minutes to discuss the hot topic of bioresorbable vascular scaffold. And we have a series of slides and issue to discuss. As we know, 3 weeks ago we had the FDA panel, and at the time of the FDA panel, the vote was almost unanimous in the sense that they vote for safety, efficacy, and the risk-benefit was assessed by the member of the panel as being favorable. So maybe we should start by Stephen Ellis and give your impression about this panel of the FDA. Was the answer of the panel fully justified, or you would have answered somewhat differently?
I think as you pointed out, the panel was overwhelmingly positive, perhaps a little more positive than we had expected, although I said we were very, very well prepared. The panel focused principally on issues related to safety and vessel sizing, and you may want to get into that further. We don't know exactly what the panel's policy will be in the United States, but it's very likely that they will provide cautionary literature and extra imaging advice for lesions that are felt to be to have diameters less than 2.75 millimeters by visual assessment. Now, we all realize that visual assessment has major limitations, so we could discuss that further.
Yeah, I think we have on the panel a majority of European and one American. Asia is not represented at this panel. What is your feeling, Philippe Urban, I mean, in terms of, and Michael Haude, in terms of sizing? Is sizing the key issue with that technology, which after all is somewhat fragile?
Well, we've certainly heard Greg Stone just a moment ago go over that data again that he presented at ACC, and he made, I thought, quite a convincing case to say that yes, small vessels were a potential real problem, and it actually drove most of the potential downsides. So it seems to me at least logical that there is a focus on that. But as I think you and others pointed out, it may also be that some of these problems are specific to this first generation device, and it's possible that in only a few months' time we may be beginning to hope that this is a thing of the past. So I don't know.
Well, Michael?
I was quite a little bit surprised when I initially saw the results of Absorb 3 having enrolled so many small vessels. If we really think about absorbable technology and the value this could have clinically, I personally believe it will be shown in the larger vessels. And if we go to the larger vessels and if we acknowledge the sizing there and the margins that you can use there, I personally believe this is not of so much importance as in the small vessels. So to be quite honest, if we want to show that technology to be superior on the long-term run over drug-eluting stent technology, we probably will have to show that for the larger vessels, because the larger vessels are the vessels that drive clinical endpoints, not the very small ones.
Right. I think that two limitation, at least of the polylactate, of derived polylactate, is that the limit of expansion is limited. I mean, there is a leeway there of 0.7, 0.8 millimeter, at least for the polylactate. We will come back on the magnesium later on. And on the other hand, there is a surface of artery device ratio, which is pretty high, 24%. It used to be with the metal 12, 14, 16. So we are really in between two difficulties. And I'm not so sure that it will change very quickly. Philippe was mentioning maybe with new generation, and we are thinking about thinner struts. But with that technology of polylactate, there are, of course, limits. So for that reason, I think that the sizing is something which is important. And I'm a little bit surprised that we are able to create very precise instrument to size, but we are somewhat reluctant to use it. And you could call that quantitative angiography of OCT. OCT is certainly very, very close to the reality. And the argument is that the budget. Is that also true for United States, that the budget, I mean, I know that the company was reluctant to associate the device with labeling that would imply the use of an imaging technique for sizing.
Well, as you know, in the United States, advanced imaging is used in at most a quarter of patients, and that poses a consideration. I'd like to dig a little deeper into the problem, at least as we understand it. So, first of all, I think that we thought that there would be an issue related to thrombosis simply because of the scaffold thickness. This is not unexpected. The issue is the magnitude. And as part of the value proposition for bioresorbable scaffolds, we expected a little bit of a problem early on for hopefully a late benefit. So I don't think we should be surprised by this. The question is the magnitude. And I think that there are at least three issues. One is it simply related to the vessel size itself, or is it related also to scaffold vessel size mismatch? Believe it or not, in the Absorb 3, I believe there were actually some 3.5 scaffolds put into vessels that were less than 2.5. Unfortunately, our eyes are not as good as we think that they are in terms of vessel sizing. So it may be the vessel size itself. It may be the fact that the scaffold is being put into a small vessel and that the so-called footprint is part of the problem. And then in Absorb 3, it only post-dilated in 65% of patients. And I think one has to ask the question, if we post-dilated more methodically, could we overcome some of these other issues? I don't have the answers to these, but I think it's not simply a matter of small vessels. It's a little more nuanced than that.
Right. I mean, I think it's clear that it is difficult to embed these struts in the vessel wall. It's part of the tissue. If I look at the slide, what is great, at least in terms of globalization, is that these trials, Absorb 2, Japan, China, Absorb 3, have been done almost at the same time. It's really the first time that we see the world working together and being prepared for the advent of this technology almost at the same time. Now, can we elaborate a little bit about what you did? You said procedure, optimization, and other option and future technology. Who wants to start on that?
Well, maybe I can make a comment. I'm not like the three of you who are definitely experts in the field of bioresorbable stents. That's not something that I have any particular knowledge about. So as a very general interventionalist, I'm still a little bit bothered by the fact that there is a definite level of complexity in terms, you have to choose easier patients, and then you have to use more technology. You have to pre-dilate, post-dilate, and often image. And so the whole thing becomes complicated to a degree, greater than the very nice, easy-to-use metallic stents that we have today. And many of my mentors actually always stressed, Bernie Meyer for one, that angioplasty was about being simple. As soon as you became complex, it had to be a transition phase, but you couldn't allow yourself to remain complex for a long time because the beauty of the procedure is simplicity. And so I'm in two minds. I understand the necessity for the imaging. We're learning a lot from it, and it's a developing phase. But to start using it routinely today, it is a nuisance to me, the fact that you have to do all this extra work for a simple lesion. I don't know, just a comment.
Well, maybe I'm the one who should respond because it's true. I mean, being a friend of Bernie Meyer, the frugal angioplasty has always been his topic. But it's clear that we were forced to go from the balloon to the stent because we could not tolerate the dissection and the late closure. Now, when we put the metal in the coronary artery, I remember personally feeling extremely guilty the first time I put a stent and did an angioscopy and saw the metal in these delicate structures. I was really feeling guilty. And then we create new problem, which was in-stent restenosis, and then we give a drug to inhibit the neointima. So I agree with you. It's a fight which makes the things more and more and more complicated. And today, if we go in the direction of the biodegradable, is simply because we want to eliminate the metal and we want to restore something which is more conform or close to the normal biology. So on one side, I'm with you, and on the other side, I think that we are fixing problem one by one, and that introduced some element of complexity. Any comment of Michael and Stefan? Do you disagree with that
I don't disagree,
historical view?
I don't disagree at all, but don't you think that these devices will become more sophisticated, lower profile, and much of the gnashing of our teeth about imaging will probably go away with second generation devices? They're going to be in the 100 micron range. They may not be quite as sleek as our second generation or third generation DES, but I think a lot of the problem, this is a transition period, I think. This is a proof of principle device, and just like, you know, the initial Cypher stent was the Cypher stent was large. Think back to the Palmas stent. I remember putting the Palmas shot. It would not go through a Judkins catheter. You had to use a multi-purpose catheter to get it to the right coronary. So we evolve, and I think that this is the first VVS. We'll have subsequent BVS, and we won't have to worry quite so much about imaging.
Right, but I mean, when you look at the option and future technology, and I'm looking to Michael Haude, it's clear that the stainless steel had, in terms of tensile strength at 500 megapascal, and now with the cobalt comb we are in the 1500. So just by changing the alloy, we were authorized to reduce the thickness of the struts. Michael, in the other direction, in the direction of the magnesium, and you have been a pioneer in that field, what do you see coming? I mean, is there room for serious improvement there?
No, I think if you look at the mechanical properties of these devices and you compare that to our permanent implants, obviously there are worlds in between. No doubt about that. But if you look at the metallic absorbable device, and the magnesium alloy currently is the one and only that reached the clinical scenario, it really turns out to have better mechanical properties than the PLA-based bioresorbable scaffolds. This is true for the shape of the device, which is not so box-like appearance with these sharp edges. It's more rounded. It can be electropolished. So all these aspects of pushability, trackability, as has been shown in benchmark tests, are improved with that and really turn out to be also superior when you have it in your hands in a clinical scenario. So the other issue is the strut thickness of these devices. To be quite honest, I mean, if we talk about that strut thickness in PLA devices, always what you get is an average value. The production process is giving you an average value, but there is some kind of variation in there. And probably this variation is not reported from device to the other devices. And this kind of variation is significantly smaller for any kind of metal device. It's true for the permanent metal device, and it's also true for the absorbable metal magnesium alloy device. So currently, I think when we talk about 100 micrometer, that doesn't mean it's 100 on an average, but it can be 120 to 80. And that is something usually which is not provided. And I think as a good benchmark kind of comparison between devices, this should be provided, because you know there are other also PLA-based devices on the shelf entering the clinical scenario,
right,
which use different technologies and probably is going to downsize this kind of variation.
Okay, so if we scroll quite quickly through the Absorb 1 meta-analysis, it's clear that statistically there is no difference, but these two curves are not strictly superimposed, and it's just a question of sample size to find the difference of 1.2 becoming highly significant with numbers. So what do you believe is going to be the profile of this curve at year 2 and year 3? Philip?
Well, of course, I don't know, but I would love to see them cross because that's what everybody's hoping for. And if that indeed happens, then it will change, I think, many people's perspective on the entire field in a very big way, because that level of difference is small. If you then get a benefit at 3 or perhaps later, 4 or 5 years, Greg said 1 to 5. So let's see. But if at 5 years they cross over significantly, then no one will worry about that difference anymore.
Good.
But I'd like to see that.
Let's see, the opposite scenario is that there is 1.2, and at 2 years and at 3 years it's 1.7, 1.9. Michael and Stefan, what's going to happen?
No, to be quite honest, actually, we need to see the crossing of these curves.
You need.
We have to. If we don't see it, probably, I think we have to question whether this technology has such a significant benefit over standard of care that it really will stay alive. But the question is when it is going to happen. Can we expect it from a device that has a fully absorption time of 4 years plus already happening in this time frame? So don't we need to wait really 5 years or even longer to see that? It's the most important question. So maybe devices that have a somewhat shorter bioabsorption period could show this crossing of curves somewhat earlier. But again, also these devices need to show it anyway, and we haven't seen it so far. And this is, I think, the big value of Absorb 3 and continuously 4 coming up there, that there's a potential due to the size of these trials, we will have a chance to see it.
Okay. So clearly a consensus, this curve has to diverge at year 2, 3, 4, 5, otherwise it will be the demise of this technology. Stefan?
Probably.
Probably.
I guess, and I would argue, though, that in retrospect, this device probably has a longevity that's a little longer than it should. And so maybe we won't see crossing as early as we'd like. We do have data on 1,248 absorb-treated patients at 2 years now. Part of this is Absorb 2. And if you compare that, for instance, to Spirit 3, there's a 2% increment in target lesion failure for both between 1 year and 2 years. So I don't see the curves crossing at 2 years. I'm not sure if they'll cross at 3 or 4. And my point then is that maybe with other bioresorbable scaffolds or devices that go away a little sooner, we might see a curves crossing. But I'm not at this point even convinced they will cross. I certainly hope they do. But there have been a lot of things that we've intuited in medicine. Sometimes they don't turn out as we expect.
We will remember that sentence. What about the hazard ratio of 2.11 at that stage between the definite device thrombose scaffold versus metal? Any comment on that, Stefan?
I think there's no doubt when you look at the data that that's about the correct ratio of 2 to 1. The question is, we were in many of these studies very early on in learning how to implant the device, and if we had used more meticulous technique, post-dilatation, maybe imaging, the question is what would that risk be? I don't think it would be 2 to 1. I don't know if it'd be 1.5 to 1. I don't know.
Looking at the curve, it's clear that it is an early phenomenon, and then it's quite stable. Then, of course, you have some report of late scaffold thrombose, but they are quite small numbers, so we should not be worried too much about that. Sure. Any comment from Philippe and Michael about this hazard ratio today of 2, technical, early days?
I think this is encountering a lot, this aspect that the device was implanted in ultra-small vessels, which accounts a lot for this aspect of scaffold thrombosis. Currently, throughout the years, we really learned, was very similar like the years after 2006 when we had the stent thrombosis issue,
right.
How to get rid of that. So I'm personally not bothering so much about this aspect, but it's still alive and it's still on the dark side of the scaffold based on scientific data available from randomized controlled trials.
I think we should mention the 4 cities experience, where an evolution of technique reduced the thrombosis rate from 3% to 1% at a year in that particular 1,300 patient cohort.
Right. So we have had this explosion of meta-analysis. First, I would like to ask you, what do you think about it, about the explosion of these meta-analysis, and some of them diverge somewhat in their interpretation. To start with you, Stefan.
Well, I think that even though we labor to get, for instance, 2,000 patient trials at the high end, we have to realize that we're underpowered for infrequently occurring events that can be very important, like scaffold thrombosis. So to put all the data together, it's important. Whether you do it at a study level or a patient level analysis will provide slightly different insights. But I think these sort of analyses are important.
Other comment?
If you're honest, if you look at the different meta-analyses, considering only the big trials or adding the smaller ones, currently the consensus with respect to efficacy outcome and safety outcome is more or less the same. There is no difference in between.
Right. But at the very end here, at least in terms of scaffold thrombose, we have passed the identity line. We are on the right side with an hazard ratio of 2. This is what has been done with the propensity match cohort of the GHOST in Europe and Science in US. You remember that initially GHOST was published in Eurointervention and triggered a lot of reaction also among the investigator. Clearly, there have been some improvement in the collection of the data. Today, this is what they have to show. It is not randomized, but it is a sizable cohort of patients. What I notice here is basically the fact of the MI. The MI, which is 2.4 for the BVS and 4 for the metallic stent with a p-value of 0.07. I am somewhat puzzled by that, since in the meta-analysis that we have done with Greg Stone, with the trial, it was the opposite. There was a p-value of 0.04, this time in favor of the metallic stent. So what is your interpretation of these type of results?
Well, I too was surprised. I think it's likely a limitation of propensity matching. And even though it's a relatively large propensity match, it's smaller than the meta-analysis. And I would give the meta-analysis more credence.
More credit to the meta-analysis.
It's also back to a point that we've already discussed in a different format, but I mean, it's possible that the GHOST registry didn't collect the same amount of information, and we know how much the incidence of MI is dependent on how often and how you measure the biomarkers. So, and that's very difficult to correct with propensity analysis. In fact, I would think you can't do that, because you either have or have not had an MI, but then how you got to that label is maybe a different way.
Yeah. We all agree that for the time being we will stick to the meta-analysis of the randomized trial and let people work. We have here on this slide the relative complex procedure for BVS. Philip was alluding to that. Is there anything else we should add to these series of advice? Clearly, because we have thicker struts, we have to pay attention also to the strut fractures, the early thrombosis with underexpansion, and then there is a few advice in terms of technique, more aggressive plaque modification, routine non-compliant balloon, routine intravascular imaging. Any comment on these recipe for cooking?
Well, I personally believe if we talk about the technique, plaque modification is important. I totally agree with Stefan that routine NC balloon post-dilatation is very important, as long as industry is not putting the device on an NC balloon, because then you probably can save that. I'm very sure and confident that the technology will only survive if we can do it like our routine procedure without intravascular imaging. For the learning curve, it is important, but currently, to be honest, I don't think that we need to combine it, because then obviously you combine another cost-driving issue to the cath lab, to a technology which obviously is also more costly than the standard of care. And especially in Germany, this is a very particular issue.
So I guess I would argue for routine imaging with the present device, at least for small vessels, because I think we as a interventional community have proven that we're not that good at sizing. On the 3.0 and up, I would hope that it's not necessary, but I think we've shown ourselves not capable of adequately sizing based upon the results to date.
But my question is there really a necessity to go down to a 2.5 millimeter vessel with this technology? Do we really believe that we can promise our patient a benefit with this technology in these very small vessels? I mean, we know if we go to countries where we have a very high prevalence of diabetes, very diffusely diseased arteries in a 40-year-old patient, probably this kind of vessel reconstruction is a different scenario that has ever been not tested in a trial like this. So therefore, I'm a bit reluctant currently to say that we should use this kind of technology in these very small vessels.
But you just raised a really important point, I think. I mean, the patients for whom you would really love to have a bioresorbable device would be the long, diffuse lesions, in particular, the mid-LAD, proximal LAD. If we can one day have a very safe approach of a resorbable device, instead of doing the full metal jacket, which we all hate doing, that, even if those curves don't cross, or even if they cross only a little, would still be a very strong incentive to use that device. But we don't have that device yet. And overlapping these sequentially in a long vessel, probably not a very nice thing to do either.
We are coming to the end. Maybe just one last question, which is not on this slide. DAPT, what would you like to use? Any advice in favor of something more strong and reliable than clopidogrel? Stefan.
So I think we don't know how long we ought to use DAPT. I think probably 12 months is a minimum, and I would consider, particularly in the smaller vessels, a second-generation DAPT for at least the first few months. I have no data behind that. It's a little more intuition.
We agree about that. Michael?
So with the data that are on the table for the BVS, I would say 12 months. Maybe for other absorbable scaffolds, as it was recommended within the first-in-man trial, 6 months is enough, because we haven't seen this issue. But in any way, we have no good scientific data to support either this or that. But clearly not beyond.
Any argument to say stay away from the polymorphism of clopidogrel?
Well, currently, if we go to acute coronary syndrome implantation, we have the open field of using the modern DAPT drugs. If we are in the stable scenario, probably clopidogrel is the thing we need to face and need to adapt. But everything else should be tested in a trial to show a benefit.
Final word?
I have nothing to add. I agree with what my learned colleagues have just said about DAPT.
So, gentlemen, I think that was a very balanced panel, if we can call that the panel of interview. I'm not surprised to hear that we are not yet there. There's still at the back of our mind some doubt about that technology. Will that technology survive? Probably well, because being optimistic by nature, I think that we will try to fix what can be fixed, but it's not going to be overnight. And I think that the upcoming years, the second, the third, and the fourth of Absorb 2, 3, and 4 will be critical, as well as the new technical development. Thank you very much for participating in this interview. Bye-bye.
Thank you.